Now this is a course on basically on the ectopia lentis, subluxated lens. It could be anything. It could be a congenital or acquired during surgery, during trauma. Everything we have covered it. This is a course we have been running for the third year in a row in the AIUS. It's conquering challenges in ectopia lentis with rings, hooks, segments and glue. I'll just run over the introduction of this course and then we'll move on to the next speaker. We have no financial interest in this presentation. Now, ectopia lentis is a displacement or malposition of the eye's crystalline lens from its normal location. A partial dislocation is termed as subluxated lens. A complete dislocation, a luxated lens or a dislocated lens. We'll be dealing with the subluxated lenses. This is basically a capsulozonular pathology which Dr. Arnab will be showing to us the whole pathophysiology behind it. And then there are systemic conditions associated with ectopia lentis. Marfan's and homocysteine are common, and the Well-Marchesani syndrome, which part of it will be shown by Dr. Haripriya and Dr. Love. Trauma will be covered by Dr. Biswas. Intraoperative, Dr. Raja Datta. We'll have pseudo-exfoliation, and if you look at the management, basically this is weak or missing zonules. There's serious challenge. Intraoperative, there's vitreous loss, lens decenter or IOL. This is what you might have, and historically we did ICC or lensectomy. Basically they have, you can in some condition you definitely have to do when the lens is dislocated more than 270 degree probably, but then that is not the ideal. We would like to keep the posterior capsule intact, keep a separation, a barrier between the anterior chamber and the vitreous, so that the complications like CME, the complication of the retinal detachment. Our first effort should be to keep the bag intact and various ways of doing it. If that fails, we'll have other ways of putting in the lens, where I'll be covering the glued IOL, where Dr. Suben Bhattacharya will be covering the other aspects of putting in the IOLs. And the basic surgical principle is, as you see, make a opening, do a rhexis, put a CTR or some oil or a Sioni, and then anchor it to the side. Now if you are successful, you could reach the stars, but at times you can find yourself in dumps, which I will be covering when I go in dumps. Basic incision thing, speakers will be covering how to start give the incision away from the subluxated area, how to start the rhexis, at which point, at which direction, hydrodissection, hooks and rings, emulsification, and IOL in the bag, and how to anchor the lens in the bag. And this is how the course would run. I invite Dr. Arnab Biswas. Well, he needs no introduction. A doyen in oculoplasty basically, and has written books, authored a lot of books on oculoplasty, an expert in the basic science in which he will be explaining us. He is from Calcutta, he is from BBI as well as Alo Eye Care, Kolkata. Please, he's here. Is present here
to share my views. Basically this is all what we all know, just recapitulation of the capsulozonular attachments and what are the pathophysiology of this zonules and how it is attached. Basically, zonular fibers were initially thought to be artifactors on histopathology, the fibers, but with the advent of the electron microscope, it was confirmed that these zonules are there, and it was confirmed in 1951 that some attachment between the ciliary body and the lens is there. Those are the zonular fibers. Basically, the zonular fibers have a diameter, these are the zonular fibers here, as you can see, have a diameter of around 10 to 12 nanometers. Periodicity, that is interval between the two fibers, one fiber, this fiber and this fiber, is around 12 to 14 nanometers, and they have been divided into anterior zonular attachments, equatorial zonular attachments over here, and posterior zonular attachments. So these are the different zones where you can see here. This is the anterior attachment, equatorial, and the posterior attachment that goes anteriorly. And sometimes when in a well-dilated pupil, you may be able to see a few of these anteriorly attached zonular fibers that you see against the transluminant red glow. Now, what are these zonular fibers? They are non-collagenous protein. These are basically composed of high content of cystine, and as we know in cystine metabolism disorders like homocystinuria, these zonules are friable and there is the quality of the zonules are weak, and that is a cause of weakness and zonular dehiscence in cystine metabolism disorders. Now, basically we would just have a short videos of the pathophysiology of how following trauma zonular attachment displaces. You have a contusion trauma, and as a result of which there is stretching in one direction and elongation in the other direction, contraction in one direction and stretching in the other direction. This causes rupture of the zonules where it is stretched, as you can see here, and that causes the dislocation, displacement of the zonules. Now, in pseudo exfoliation, what you have is pseudo exfoliative materials get deposited on the zonules as well as on the anterior capsule. Now, this contains lysosomal enzymes that are there, and this lysosomal enzymes, proteolytic enzymes, causes the weakness of the zonules separate, and that causes when you are doing a phaco or a cataract operation, the rapid movement of the capsular bag, and as a result of that movement these zonules rupture, and usually in pseudo exfoliation perioperatively you can have zonular dehiscence. So one should be aware of these conditions during phacoemulsification. Next is the Marfan syndrome. Now, what happens in Marfan syndrome is the zonules are intact, but because of the defect of the fibrin in the gene, the zonules are stretched up. So as a result of which some zonules are stretched up and some zonules are weak. So that causes the contraction of the lens into one direction, and usually superiotemporal. And what important finding is, because the zonules are intact, the accommodation is also present in this type of situations. Now, in Marchiani syndrome, what happens is, as the lens is spherophakic, that means it's small in comparison to the size of the normal lens, as a result of which it displaces, and that can even cause the pupillary block and resulting in different types of glaucoma. Excuse me. Now, in homocystinuria, what happens, as I was discussing about, the zonules are brittle. This zonule brittlity causes this stretching, rupture, and as a result of which, usual cases, due to gravity, the lens shifts inferonasally in this type of situations. And one important finding is, as the zonules are ruptured, their accommodation is absent in this type of situations. So these were the few pathophysiologies why this subluxation of lenses takes place, and my next speakers would be sharing with you the management of different difficult situations that one encounters in his or her private practice. Thank you.
Thank you.